Thank you, Bethany. Good morning, everyone. It is fabulous to see you all here, and I'm thrilled to be celebrating the 10th anniversary of the Center for Public Health Law Research. Welcome to Temple to all of you, and for those of you who have traveled from outside the area, welcome to Philadelphia as well. I think ours is a really wonderful city, and not the least because of its rich history of innovation. Dating back, I think we can say, to the first few years of our nation, when just down the street from here, the founders developed the Constitution, which was obviously a very legally innovative document and structure. Today, we're of course here to celebrate a more contemporary form of legal innovation, the growing field of legal epidemiology, which also has roots here in Philadelphia at Temple's own Center for Public Health Law Research. It has been a privilege and a delight for me to get to work with and help support the great work that the center is doing. It resonates so strongly with our institutional conviction that just laws are essential to human well-being. As today's agenda affirms, this work that we're talking about, your work, provides new tools and methodologies for grappling with some of the most challenging policy issues that are before us as a society today. And of course, our celebration is not just about looking back upon what you have accomplished, but also looking forward to what lies ahead. Here too, I think legal epidemiology can help push legal education and more broadly, the legal profession into new and exciting directions. How can we as an institution invite students to think about the law differently? How can Temple Law School and other legal institutions that are focused on legal education train students to not only understand that law and policy are interventions that can impact health, well-being, and equity, but also figure out new and better ways to measure and evaluate the extent of that impact. I am proud that Temple Law School and the Center for Public Health Law Research, in collaboration with the College of Public Health, are leading the way with the nation's only certificate in legal epidemiology. And I look forward to seeing the future innovations that you develop down the road. A second contribution that comes to my mind as I think about the impact on legal education is best reflected by my view from the podium of you this morning. It's you, an assembly, an interdisciplinary assembly of lawyers and scientists and academics and policy makers and officials from every level of government. Your diversity is a wonderful representation of the transdisciplinary nature of this work and the immense benefits that we realize when law itself is understood as a transdisciplinary study. I'm honored to welcome each of you here today to Temple, and it is now my honor to turn things over to Scott Burris, someone who himself is a visionary pioneer in legal epidemiology, my friend, my colleague here at Temple Law School, Scott.
Thanks, Greg. Welcome everybody. I have just one word. And it's not plastics, for those of you who are film buffs. It's thanks. That's really the only word that you can start with, and probably the word you should finish with when you've had an enterprise that's gone on and survived in the world of research and fundraising and field building for 10 years and still thrives. There's thanks to a lot of people in this room who started it all up. and people who work at our center. I mean, certainly thanks to Bethany for all her work to arrange this, and the whole team at Temple that makes these events happen. And of course, thanks to our funders and all the people who've continued to support us, and our colleagues all over the place. I hope that today will, in some sense, be an effort to put those thanks in the form of interesting panels that carry the work forward. So I suppose I also misled you when I just said one word, because there are a few other words I will say in introduction. I think Greg has actually caught things pretty nicely. For those of you who have not run into legal epidemiology as a term of what we do, or are just starting to dig into it, my suggestion is just Google that term, and you'll find lots of articles and videos and presentations and so on, and see what it's talking about. But the essence of it, the essence of what this panel or set of panels today represents is this idea of transdisciplinarity. The idea that in the world that we live in today, not much important change can happen in particular topical, professional, organizational, governmental silos. Problems are too complicated and too interrelated, and solutions have to be that way too. And it's not just that we have to work together to implement things, it's that we have to work together to understand things. We're all kind of highly aware of how standpoints and worldviews can differ today. It seems like, a lot of our public life is just a kind of battle of partial visions that believe they are complete. But in academia and I think in the day-to-day work of problem solving in government and organizations, I think we recognize that nobody has the right answer from one point of view, that there's a lot of voices and ideas and approaches that have to be included to actually comprehend this complex world we live in. And it's just as true of law as of any other kind of activity or discipline that's working out there now to keep us on the right track. So today's panels are in that spirit. They represent this idea of transdisciplinarity. In our work, we are as likely to work with sociologists or epidemiologists or economists as we are to work with other lawyers, and that's a good thing. And that means that our panels should also have this kind of diversity of expertise and experience. The voice of practice and experience is also really important. That has to be included, and that's included on our panels. And finally, I think the broader, voice of the community in the field has to be involved, and that's why presenters willing and being compliant, our aim is to have a lot of time for discussion. Our panels will generally have short presentations that introduce some key ideas that you can, as they say in the wonders of the internet, dig into more deeply based on your interest. And then our panelists will talk to each other a bit about the ideas that have come out, and then we'll open it up to the whole group. And even the people on the webinar to put in questions and comments and allow us to share a rich day of thinking about these particular topics. And then finally, we'll finish with a session where we're just kind of going to talk as a group about where this kind of work and this kind of research should be going, what it should be doing. How can we use the immense resources we've been given and the opportunities that stand before us to do what public health is all about, trying to produce a better and fairer level and distribution of health for everybody in the country. So with that, I'll just have one word, just one word, go. And I am our first panel moderator, so we are now going to move into our first panel. So if I could ask our panelists to come up to the front and join us. And while they are doing that, I'll take a deep breath and then start to introduce them. This panel is about cities and about work at the city level, impediments to work at city level, opportunities for work at city level from a public health law point of view. we're all, we start with a panel like this out of experience and observation. We see that around the country and across public health topics and social change topics and social improvement and social management topics, cities are often in the lead. They're the ones who are coming up with new approaches, and they're the ones who are stuck with what happens when old approaches don't work. Higher up politicians can kind of pass the buck, but mayors and city councilors, there's nobody that they can point to when people need help. So cities are the coalface of public health, as well as being the opportunity space. We are really privileged to have several people who on this panel who are artists of working at the city level and who represent enterprises that are doing really important work. Our first sort of mini keynote speaker will be Shelley Hearne of City Health. And I'm going to let her tell you all about City Health, so I won't say any more about it except to say it is so cool. And I'm glad that she has a chance to share it. But Shelley is also really cool. Somebody who for really a long time, well, she doesn't look at, has been a leader in positive change for public health in policy, founder of the Trust for America's Health, and somebody who, all the people who are worth knowing know Shelley and rely upon her judgment and expertise. So you'll see that. I won't say anything more. Now I got to do my glasses so I can read this. So Geoff, Mwaungulu from NACCHO is somebody I've also known for actually a really long time, from the time he was an intern at the Robert Wood Johnson Foundation. I remember meeting him and saying, whoa, this guy's really got it. He's gonna go somewhere. And not too long after, he went to be, I guess, your senior program analyst for public health preparedness law and ethics at NACCHO. That's the title, but I mean, what it means, he's kind of the go-to guy to think about law at the organization that represents the city and county health officers, of whom there are like thousands in this country, the people who are working at the city and county level to do public health work in their agencies and their needs and their concerns, which are many. So Geoff will be our first speaker responding to and adding to Shelley's discussion of city health. One of the founders of the Center for Public Health Law Research and the Public Health Law Research Program, somebody who was with us the entire time that we were giving out money on behalf of the Robert Wood Johnson Foundation. But somebody, again, I knew, another person I met long ago, we actually met in Canberra, right? In Canberra. So we were both at the Australian National University and both kind of hanging around with really amazing criminologists. And I didn't succeed in becoming an amazing criminologist, but Jen already was, and since then has luckily come to Temple. She wrote in our methods textbook. She wrote the chapter on qualitative research, but just somebody who has been doing incredible work at the local level in this area on how communities and police and law and security generally can happen and interact. So she'll be our next commentator. And then finally, somebody who I've only more recently come to know, but we've been working together the last couple of years. Alice Jones from the National League of Cities. Again, another one of these crucial glue organizations that tries to take all the needs and all the ideas of cities and find a way to through self-help and coordination to make more out of them. So we've been working with Alex on a preemption project, and he's gonna add a little bit about that into the mix because that's another important legal theme for cities. So without saying anything more, and you now know who you're dealing with, I'm going to turn this over to Shelley to start. Well, do you want to move? I can move your slide. Stand up. Stand up. Yeah. We'll do the conversation.
Good morning, everyone. I got very nervous with Scott's introduction. So let's see if I can live up to, we get a little wild here, a little artistry, a little connecting some of the dots, but I feel like I have to start by stealing your first word, which is thanks. I'm going to talk a little bit about what city health is, but I say thanks because it would not be possible without this fundamental tool of legal epidemiology. Scott had mentioned I had founded Trust for America's Health. I worked for years running the Pew Health Group. Basically spent a career doing surveillance work of policies and initiatives at the state and national level for public health. And a lot of the work that we did, classics, actually yesterday, Trust for America's Health released its annual report on obesity in the country. And it ranks the states as to who is the heaviest. And it shows, unfortunately, the trend. We now have 9 states that have surpassed the 35% mark. But if you take a look carefully at what a lot of the work I've done in these organizations have done in the past, it's measuring health outcomes, but having a challenge on how do you talk about the policy solutions for addressing those public health crises? Whether it was obesity, we would also always put out a report on preparedness. It measured the readiness of states for a major public health emergency. And what we would do is try to find various metrics like number of epidemiologists, the capabilities of the public health laboratories, a number of metrics that we could then tie to the issues that these states were addressing. We had a tough time measuring what were the actual policies that were in place, that were working, and that were making a difference, and do it in a quantitative way, the way we could quantify various health outcomes. And particularly when you're focused on upstream solutions, you want to be able to have that kind of database, or at least a quantitative way to talk about what's happening in what place, how they compare, and use that information to really help policymakers understand what their gaps are, what's working and making a difference in other locations, and using that public information to help drive and catalyze change. Well, lo and behold, thanks, this policy surveillance methodology was really the building block for this concept of city health. And what city health is, which is the time to hit the button, it's basically a very focused effort, an initiative by the De Beaumont Foundation and Kaiser Permanente to identify what are the critical laws that should be on the books in the city in order to create the healthiest place, living conditions possible. And it went through a framework. I can say this is a safe space, right? I can say social determinants of health. I would never say it out in public because no one has any clue what it is you're talking about. But when you're with policy wonks, it's safe. It's an okay space. We essentially identify what are the key areas that are drivers on health outcomes: education, housing, finance, public safety. We went and looked through the extensive literature, predominantly tapping things like CDC's Community Guide, the Institute, I shouldn't call it the Institute of Medicine, the Academy of Medicine, Robert Wood Johnson's great curation on action policies that could be done, and looked at what were the best evidence policies in each of these areas, what then fell under city jurisdiction. And then we took it through a pragmatic test. We brought together a group of city influencers, whether they were mayors, we had representation from NLC, we had members of NACCHO, we had community leaders and organizations, a wide range to basically say, okay, could you support this policy of packages? And went through this process of filtering to come up with 9 specific policies that we would then score cities. And because of the surveillance methodology, what we were able to do is, with the assistance of legal sciences Temple team, we were able to code and create a criteria set measuring those policies in the 40 largest cities. And with that data set, we could not only cross-compare what was happening in different places, who was doing what best, where the gaps were, but we created a simplified gold, silver, bronze, and no metal structure. Because, I'll steal it from James Carville, for those who remember him, just keep it simple, stupid. You know, it's the mantra of, if people are going to understand, and whether it's translating to the public or policymakers, a framework that really says, okay, here's your best policy possible. Here's something that is good, makes a difference, and is in place. Bronze being adequate, it addresses some of the social needs, though there are still elements that could improve. And then a no metal reflected, even if it had a policy on the books, but it didn't hit the basic needs that would create those health outcomes that we were focused on, we would not score it as metal. That was a fairly extensive process to come up with that framework. And then having the surveillance methodology on these 40 cities was a laborious task, which not only took a team of lawyers, but there was an extensive quality assurance, quality control process that was done engaging members of each city to have a chance to review and assess that data. I suspect we can talk about that a little bit more during the panel session. What we were trying to do, when I referenced some of the work for Trust for America's Health or Pew Charitable Trust, a lot of those reports kind of fall into what we would call fondly a rank 'em and spank 'em methodology. And it essentially was just by putting those scores and rankings, it created a sense of who's doing best and who could be doing better, who are the laggards. With this framework, it was really a very different structure. And I have to say is, I don't know if I'm a reformed ranker and spanker. This is having a very different outcome. While shining a light in an advocacy, it can be helpful for both the policymakers and advocates outside trying to create policy change. Creating this metal structure and also working with cities has created a dynamic where the cities are coming to us and saying, okay, what do we need to do in order to get a gold medal? What are the policy fixes that we need to put in place? What can we do to get these 9 on top and on the books in the best possible city? And we've had an extraordinary surge of interest and engagement by the cities. This is just reflecting what, again, I had mentioned in terms of the filtering process of how we got to those 9. What I want to really get to is what are those 9? What we identified were inclusionary zoning as a part of affordable housing. We have a series of laws that analyze the safe alcohol sales, basically correlating to the data that shows the more densely populated alcohol retail outlets, the higher association with violent crime outcomes. Alcohol is associated with almost a majority of homicides in this country. It is a high association with violent crime, domestic violence, and motor vehicle accidents. Complete Streets is the policies in place to ensure that regardless of age, ability, and income, that there is safe and alternative modes of transportation. The earned sick leave is assuring that policies are in place for all city employees and anyone contracting with the city. The food safety is basically a right to know policy of translating the everyday inspections that are going on by health departments, taking that, translating into a score, an A, B, C. Seattle has done emojis because of the vast cultural considerations in the city, and having that as public facing as a part of a consumer's decision making, which is shown to actually have a reduction in foodborne illness hospitalizations. Healthy food procurement is putting nutrition standards in place in any of the food sold by a city. We also have a requirement of universal, high-quality pre-K, again, in the area of education. Having solid pre-K is an extraordinary boon on health outcomes, everything from reducing teenage pregnancy, increasing high school outcomes, smoke-free indoor air, and then tobacco 21, raising the age from 18 to 21. So for the epidemiology world, we went through the basic process, collecting and coding all the relevant executive orders, statutes, regulations, and scoring those for each of the cities. We did, again, through the team here, a process of double coding so that we would have the ability to internally ensure accuracy of data, but then we also sent this out to cities to verify. We worked with the leading national organizations to help us identify those criteria and components required in policies to identify the gold, silver, bronze, and no metal categories. And lastly, as I keep repeating, but it's an important piece, we actually worked closely with NACCHO to reach out to cities and make sure they had a chance to take a look at the data. We gave them an overarching gold medal if they had at least 5 gold medals out of the 9 policies. We gave them a silver overall if they had 5 gold or silver medals. And bronze was simply having 4 policies that medaled. The 2018 findings, I wish I had Philadelphia in gold, and we're urging the city to get that direction, but we had 5 cities that hit that mark. We've got, as you can see, and you can trace back your city of interest. What's happening right now is we have created technical assistance programs because of the demand and interest that we've found by city leaders, mayors, city council members, and sometimes the community groups in these cities to come and work with us on how to improve their policy outcomes. The volume of interest has been stunning. And what we saw, in part, as we interacted with these cities, in providing really a range of support, everything from providing grants to places, organizations like Campaign for Tobacco-Free Kids, American Heart Association, local organizations that we work in this area. I thought a variety of pieces directly to the city as they were wanting to do. Something of the part of what is really the center of policy change. It's not just the incubator and innovators, it's actually creating a wave of momentum to move state and national policy. And that's part why we focused in on the cities, because that's where the action was happening, is where there were mayors and city council members who wanted to be health champions, who looked at it as a health in all policies approach. And they really wanted a menu, and they wanted support, and they wanted attention, and boy, did they love their medals. We did medal ceremonies at the U.S. Conference of Mayors, and we placed 5 medals on people, and I can't tell you how many mayors and city council members came up and said, what do we have to do next year to get our medal? I said, well, put some money into pre-K, get that complete streets law passed. We had a to-do list thanks to the legal epidemiology and score charts. It appears that we're on track this year to have very similar numbers. And it comes from places like San Antonio, which had scored as a no medal in 2017. And the mayor and the health commissioner, Colleen Bridger, who was brand new in San Antonio, knew about City Health and convinced the mayor, as part of her coming on board, that she wanted to have the city move from a no medal to a gold medal. And the way she'll describe it is, you could see his calculus of, did I just make a crazy hiring decision? But he committed to it. And they wanted to not just do what might be low-hanging fruit policies, but they decided to start first with raising the tobacco age from 18 to 21. San Antonio's in Texas, you know that, right? That's not really a popular thing to do. And in fact, when we called the tobacco advocate groups to say San Antonio's wanting to take on Tobacco 21, there was this scream, no, don't do it. Because they had just lost in Austin. They lost in Houston. They had tried in a few other cities, and there was a retreat because the fear was that dirty word of preemption was going to get taken on by the Texas legislature, and any efforts on trying to move this tobacco age was going to get shut down. But Colleen Bridger and Mayor Nuremberg, that was just, it's Texas. That was like, bring it on. All right, we're going in, whether the community is with us or whether the advocacy community is with us or not. We know what is going to make a difference for our citizens. Despite this being a military town, they not only rallied the troops and passed Tobacco 21, but they have now put in place the complete streets. They're working on the procurement pieces. They're taking on, they've received a goal for their extraordinary pre-K program with high access numbers and quality benchmarks. And don't tell anyone, I know this is on webinar, but we will be giving them a gold medal this year, and it only took them 2 years. And they doubled down, they said, this is what we're going to do, and we're seeing this in many cities across the board. This is not boutique or, the kind of just a coastal entertainment. This is actually, we're seeing this in Kansas City, we're seeing it in the heartland of this country where people have been, no one yelled about the scores and the medals. What they said was, thanks for giving us this information, giving us a pathway, and giving us the support and recognition for the work we're doing on improving health through policy change. So thanks, and I'm going to wrap up there.
Thanks, Shelley. And now I'll turn it right over to Geoff.
Thank you very much. Good morning, everyone. As Scott mentioned, my name is Geoff Mwaungulu. I'm a senior program analyst with the National Association of County and City Health Officials. Scott, I appreciate that you shared that story from earlier about my first time meeting you. I'm not sure if you remember the exact first time. So I met you twice when I had my internship. I came over to Temple with my colleagues to learn more about your program that you're having here. My first time I met you was my first day on my internship at Rebel Johnson, where you're reviewing applications for your program. And needless to say, my first day of my internship, I was very overwhelmed by this world of legal epidemiology. However, over the years, it's been, and I should say actually over the course of my internship, it was I came to find out that it was very easy to understand a concept that was groundbreaking. And I found that I really wanted to be involved in that world as I moved forward in my career. And so at the National Association of County and City Health Officials, I work on public health preparedness, law, and ethics. The majority of my work is actually in public health law, where I lead our efforts towards improving the capacity and capabilities of our local health departments in practicing law, in using the law as a public health intervention, and understanding the place of law for public health, the practice of public health. And so Again, thank you so much for inviting me to be up here on this panel. I look forward to providing you with information about what we're doing at NACCHO in this world of legal epidemiology, learning from my fellow panelists about what they're all doing, and learning from you all, not only in the room, but online, to find out where your interests lie in this world and kind of where synergies lie, and just kind of move the conversation forward related to counties and cities. And so for one of the most important things I want to share with you all, who is NACCHO? You see the nachos there. And this is something that one of my bosses put together. He was very proud of this slide. The animation, of course. So we're all guilty of it, myself included. The first time you see our acronym NACCHO, you want to say nacho, but we are NACCHO. We like to make things difficult on folks and call them out on it at conferences and things like that. But we are the National Association of County and City Health Officials. We represent all of the local health departments across the country. So there are nearly 3,000 local health departments across this nation. The local health departments, in our minds, and we believe in everyone else's minds, they serve as the backbone of public health practice in this country. And so our mission is to serve as a leader, partner, catalyst, and voice with local health departments. So we don't necessarily encapsulate the opinions of every local health department. Nearly 3,000 of them are out there, but we like to think that we're a partner with all of our members, and we like to think of ourselves as kind of leading efforts with our members, as well as providing voice with our members. And so we're able to kind of convey at the national level kind of what's happening at the local level, and also vice versa, bring down some national level ideas down to the local level and implement them across these communities across the country. Thinking about adding a sentence to that mission to include the creation of difficult public health acronyms. So what does it look like across the country? The geographic jurisdiction served by local health departments. And so this is taken from our national profile. If you haven't had a chance to look at this, it's free, it's online. We update it every 3 years, so the next one's coming out soon. This one's from 2016. But here we see a breakdown of the local health departments and the jurisdictions in which they serve. And so you see at the bottom right-hand corner, there's a different distinction of the 4 different categories of local health departments, at least the jurisdiction that they serve. We have city or town, we have county, multi-city, and multi-county. And so I think it's easy to see up there. Yeah. So you can see from the different color schemes, there's a lot of variety across the country. There's a lot of variety across the nation. Our local health departments are representing very diverse communities. We have our cities that are representing very dense populations, very high, large populations. And we have our frontier health departments, mostly out west, that are representing less densely populated communities that span huge geographic areas. So drum roll. So just digging a little deeper into that, kind of the LHC landscape, just want to provide some information related to the percent of U.S. population served by local health departments. And so I think the most important thing to take away from this is just that distinction between the large health departments serving over 500,000 and the small ones under 50,000 folks. And so looking at that large one, so we mentioned 3,000 health departments across the country, 6% of those 3,000 serve 51% of the folks in this country. And then on the other side of the coin, at the other extreme, 62% of that 3,000, they represent only 10% of the folks in this country. And so there's a lot of variation in what's happening at the local level in terms of the responsibilities of local health departments and just who they represent and who they provide public health for. And so when you're looking at the different variations that exist across the country, it's just something to keep in mind as NACCHO tries to address its work. It's just taking into consideration the different levels of capacity around the country, the different levels of resources, the different levels of responsibility, and those that are being impacted by the work that we do. And so we've all seen this before, the essential public health services. So this is just in here just to reiterate the fact that there's so much variation in those health departments that exist across the country, though they're all basically trying to get to the provision of what we see here on the screen. This is the foundation, the bedrock of public health in our country. And so let's move on to kind of law and policy. And so these two buckets, traditional public health legal practice, legal epidemiology, I think many of us have seen this before. This is from the paper that Scott and his colleagues have written on the transdisciplinary approach to public health law that has made such a huge impact on our public health practice across the country. But on the left-hand side, you see that traditional public health legal practice that's looking at kind of what we think about as the practice of law. So it's looking at counsel representation and legal research. And we have our legal epidemiology, which has our policy surveillance, and it has the consideration of law and policy in terms of improving the public's health, as well as considering potentially those laws and policies that have a negative impact on the public's health as well. And so when we look across the country and look at the different local health departments and kind of their capacity in these two different areas, there's a lot of variation, but I mean, the challenges are generally the same once you start trying to categorize them. When you're looking at traditional public health legal practice, large health departments, small health departments, many of them are, they're impacted by many of the same challenges. So that's finding attorneys that could represent their needs, that are able to provide counsel, that are able to do legal research. That's considering different resources that are out there that could provide that technical assistance for many of these local health departments. The larger ones are more likely to have in-house counsel and folks are able to help them out, or staffs even. But they still also have some issues sometimes where they have to utilize attorneys that are shared across different agencies at the local level, or they may have to utilize a state level attorney. And the same goes for the small health departments as well. There are a lot of organizations out there that help out these different local health departments in order to provide kind of that legal expertise. One that we're all very familiar with is the Network for Public Health Law and the CDC Center for Public Health Law Practice. And they've done a great job in helping out our members in their ability to kind of think about this traditional public health legal practice. And you think about legal epidemiology on the other hand. And so the same variation exists. There's many challenges that both large and small health departments are faced with in order to consider undertaking policy surveillance, to consider adopting laws that positively impact the public's health, and also considering kind of what laws are out there on the books that have a negative impact on health. The same goes here. There's many resources out there to assist those folks who aren't able to do this in-house. We just heard a great presentation from one of those resources. And something else to consider is just that when you think about the local practice of public health, some of those laws that are existing out there are at the local level, those ordinances that exist that only impact those jurisdictions that are represented by local health departments. And so there's a lot of challenges that are involved in trying to understand kind of what to do about those local ordinances that make an impact on local health. And so some common challenges that face by all health departments are creating and accessing local legal databases, and that's in relation to that policy surveillance work. And so there's resources like City Health, but for those smaller jurisdictions, they need to have access to those laws, looking at a longitudinal perspective and seeing kind of what those impacts are on their populations. There's navigating resource limitations, there's building local momentum, and local momentum includes community-based momentum, so trying to get community groups together as well as political forces as well. And there's plotting next steps in law and policy adoption. And so that's taking the ideas of the laws that you want to put into action and putting them into reality. And so there's that kind of step that's missing there often for many local health departments and their partners. One of our members, Dr. Rex Archer with Kansas City, often mentions that there's the idea of kind of different policies you want to undertake, and then there's the reality, but then people just think that the middle step is just magic happens. But there's a lot of activity that has to happen with that magic happening. And so that's something that we're trying to focus a lot of our efforts on at NACHO, is trying to bring those resources to our local health departments as to how to make that magic happen, at least in the policy surveillance world and legal epidemiology world. And so on the screen here, you have some information related to kind of the different areas in which we support our local health department efforts. And so we kind of distribute resources and ideas, work with our partners to share that information. We convene folks to discuss these items at our national conferences, and we help them create local partnerships, especially through our Mobilizing for Action through Planning and Partnership program at NACCHO. We advocate for them on their behalf, and we provide trainings where we're assisting folks in understanding how to create action plans towards putting together a policy, getting the community to back it, and then trying to understand kind of how to get it accepted. And so with that, I'm at time, but thank you so much, and I look forward to our conversation in a few minutes. Thank you.
Jen, you want to go from the webinar?
Good morning. I appreciate this opportunity to talk about a growing subfield of public health law research, which focuses on the law enforcement practices of police on the streets of our cities and their implications for public health. This subfield is commonly referred to as LEPH, or Law Enforcement and Public Health Research. This subfield was formed collaboratively by efforts from researchers, practitioners, advocates, policymakers, coming together with a shared vision to change the ways in which policing is carried out on the streets of our cities in furtherance of improved public health. And central to this was, how can we reduce the health risks, the health vulnerabilities of the individuals that encounter police routinely on the streets of our cities? An important feature of this subfield has been a reframing of some of the most critical law enforcement issues we face today, including the opioid crisis, gun violence, as public health issues, rather than more narrowly law enforcement issues. There are different levels at which this reframing is taking place, at the county level, at the state level, at the national level, but I'm going to focus briefly today at the city level. So what do we know about the relationship between public health and the street level law enforcement practices of police in our cities? We know that police are the gateway to the criminal justice system, and we know that police officers make routine decisions every single day that influence whether people with health vulnerabilities, such as substance use disorders, mental illnesses, and even chronic physical illnesses, will end up in our nation's jails and prisons. We also know that structurally disadvantaged populations, including people experiencing housing instability, are at heightened risk of encountering police and being justice involved. And thanks to some new and novel integrated data sets that track a range of outcomes of individuals who flow through our justice systems and through our emergency departments in our hospitals every day, through our jails, we now have a much clearer insight, and it's a troubling one, that there are subgroups of individuals with complex, unmet health needs that are caught in a vicious cycle of being caught up by police, being arrested, visiting our emergency departments at disturbingly high rates. This is the problem of repeat cross-systems involvement. There was a new report that just came out by the Vera Institute of Justice concluding that police have been engaged in an over-reliance on punitive enforcement on the streets of our cities. But most often, that enforcement is in response to very minor offenses. So the bulk of the law enforcement that takes place on our streets is not in relation to violent crime, but in relation to drug use violations, disorderly conduct, and what we colloquially refer to as quality of life behaviors. This over-reliance on punitive enforcement is particularly stark when we look at the handling of police encounters with people affected by serious mental illnesses. More than 1 million adults with serious mental illnesses are under correctional supervision in the country. And within this population, there are subgroups that are shifting between homelessness, medical institutions, and the criminal justice system. We know that once you're in jail, effective treatment can be delayed, that the unmanaged chronic illnesses are not treated, and that the healthcare costs of treating justice-involved individuals skyrocket. And similar observations can be made in relation to people affected by substance use disorders. So what are cities doing now that we have quite a clear evidence base on the harmful effects of criminal law enforcement for public health? The city of Philadelphia is functioning as a real-world laboratory in this area. And at the heart of the work that's going on here is really a quest to provide police with alternative tools to law enforcement tools when they are handling encounters affected by people, with people affected by mental illness and substance use. These efforts are part of a broader agenda to reduce the use of punishment and incarceration. And this agenda is an ambitious one because it necessitates new types of workers, new classes of workers that work with police. And it also requires new institutional arrangements to support the police as they try to do things differently. One area that is the focus of work both in Philadelphia and across the country is police-assisted diversion. In Philadelphia, there's a pilot program now, the PAD program, offered for low-level, nonviolent drug users, people involved in sex work, in minor offenses. There's pilot zones that are operating now. And the focus is to divert people away from the criminal justice system and toward more supportive, peer-based social services that are customized to people's needs. We also have a mental health responder program involving trained clinicians. Researchers, medalists who are doing great work. What should be the standards for doing gold medal work in this area? The conference that's happening next month in Edinburgh has approximately 17 countries represented in terms of bringing everybody together and talking about what are we doing in cities to improve the work of the police. So Philadelphia is not only working locally, but is really participating in a global conversation about how cities around the world are transforming criminal law enforcement on the streets. Thank you.
Thank you. Good morning, everybody. So first, thanks to Scott and the Temple team for inviting us from NLC to come present. And I'll also just note that I think it's really fitting that we're kind of bookending with Shelley's work, because she had this great insight, right? That cities and city leaders are so eager. When you give them kind of a framework to implement solutions on, they will chase it and they will go right after it. Unfortunately, I'm here to talk about some of the constraints they face and what they're not able to do as a result of some state preemption laws. So first, just some background on who NLC is. We are kind of the largest national representation of cities, towns, and villages in the country. We represent around 2,000 cities and municipalities directly, but through our state leagues, we represent all 19,000 municipal governments in the country. So we were founded by our state leagues. There's 49 of them. It's your fun fact of the day. There's one that's does not have a state league, and that is Hawaii, because it only has one municipality. And so traditionally, kind of our state-based work has always sat with those state leagues, policy work, advocacy work. But we were approached about 2 years ago by our state league directors around this issue of preemption. I think there was this growing realization that this was an issue that wasn't just unique to their state. It wasn't about bad relationships between the mayors and their governor. This was kind of a more systemic trend that was kind of constricting the ability of local leaders to deliver policies locally. So for those who don't know, preemption is the use of really state or federal law to nullify municipal ordinances or authorities. So it can happen in any level of government, but we're kind of focused on the state preemption. And I'll also note here that preemption isn't good or bad, right? It's merely kind of a legal tool that's used to resolve conflicts between different levels of government. But what we're concerned with is what we perceive as kind of a rise in what we would call the abuse of preemption, which is when state governments are passing these laws really without kind of hitting a threshold of reasoning for why they're passing them. There's not other laws in conflict. There doesn't seem to be a real need for statewide uniformity, but instead we see kind of this patchwork argument being thrown around. And so what we've done over the past 2 years is kind of an initial survey of some preemption laws. We surveyed for 2 years consecutively in 2017 and 2018, 7 policy areas that we saw to be ones where there was frequent conflict. And I'll just run through these quickly, right? Things like minimum wage, like paid sick leave, ride sharing, municipal broadband. So these are all kind of a broad swath of policy areas. But what we found pretty quickly is that this was a great data set, and it got very popular. There wasn't a lot of information out there on state preemption, especially across a wide swath of policy areas. But what you also note is this is basically a binary data set, right? And I think one of the big challenges for the field is that a lot of the information that's out there is just preempted or not preempted, and it's really not getting under the hood on what those state laws are actually restricting. And, frankly, we put this out, and there were other advocacy organizations and research groups in the field on kind of more narrower. So a lot of folks are really concerned with minimum wage preemption, and there were conflicts. There were conflicts in the national data sets that we saw. And it was one of the big reasons that we really were excited to partner with the folks here at Temple in order to bring a little bit more rigor and a little bit more granularity to these kind of preemption data sets. And I'll get into that project a little bit more in a second. But first, I just want to go through just kind of a few of the principles that we think about when it comes to preemption for NLC. And why we think this is an issue. So number one, for us, preemption violates the spirit of home rule and local self-governance. So most cities in most states operate under some form of home rule. So I'm hedging there a fair amount, but basically, we believe that local governments should be empowered to govern according to the wishes of their residents, provided they are not violating any kind of fundamental civil and human rights or violating the kind of dictates of higher levels of government. And so what this preemption does is really kind of it's kind of breaking that relationship, that trust that should exist between the city and the state, and kind of comes off as slightly more paternalistic from the state level. Two, for us, almost more importantly, is the preemption kind of undermines the faith in local democracy. So this for us is the relationship between our members, the city governments, and their residents. We have seen a lot of instances over the past couple of years where there's actually been local referenda passed, where the residents of the city have expressed their wants, their needs at the ballot box. The city officials have gone ahead to implement that, and they've been struck down by their state. In some cases, raises in minimum wage, for example, in St. Louis, have been reversed, even though the residents there have demanded them at the ballot box. So for us, we think at a time right now, especially when there's already kind of a fracturing in the faith of a lot of political institutions, that this is just one more kind of straw on the camel's back here, where people don't believe that their government can represent them or represent their wants and needs. And then third, and I think this is really relevant, especially to the public health space is we're concerned that preemption limits policy experimentation and innovation. It really keeps us from knowing what works. We often hear the states are laboratories of democracy. Anyone at the city level will tell you that cities are. Scott alluded to this, that this is where we're seeing a lot of new policies being put out, new programs being put out, and the benefit there is you can measure their success. You can see what works and what doesn't, and basically what preemption does is it takes every city within a state and it makes them implement the same policies. So there's some nuance here, right? There's some preemptions that would be called floor preemptions. We can get into this if we'd like, where they're basically setting a minimum standard for the state and allowing cities to legislate or pass ordinances with kind of higher levels of regulation. But what we're seeing too often is what people would refer to as ceiling preemption, where it's really saying that this is as much as cities can do. And what that does in effect is it creates a single uniform standard across the state. So a lot of the interesting policies, a lot of the policies that we see in the city health playbook, for example, and others, there are just cities and states who cannot implement them. And this is really concerning because really what it's doing is taking tools out of the toolbox for local elected officials, for local public health leaders. And so we've even done some work with City Health. We're in the middle of it, looking at those places that are preempted. Are they also at risk for some of these public health issues? And preliminary, we see yes. Like we see that places who have above average smoking rates, for example, these are the same places that can't go ahead and legislate on some of those, tobacco 21 or clean indoor air policy. So for us, it's really concerning both at for these individual cities, but also kind of at a national level, because the hope here is that things that are proven at the city level can bubble up and that they can be expanded into higher levels of government. But where we're at now is really just a policy freeze out, frankly, on a lot of these issues. So one of the reasons we've engaged with Temple here is to bring some more rigor, some more granularity to a legal data set around preemption. And so we're in the midst of it, should be done very soon, actually. And the goal here is to be able to get beyond that binary, preempted or not preempted, and really dig into 11 policy areas that we believe are actually critical to public health and health equity. Some shared with the city health folks, and we have kind of two goals here. So I think on one hand there is a real need to build up the field of research around preemption. There's a real mismatch in the disciplines, frankly, on a lot of the folks who want to be doing research on kind of the impacts or the causes of preemption, and those who can put together the legal data to be able to do that. So, as I mentioned, we put out a data set 2 years ago that was fairly basic, and it's been cited and used repeatedly by researchers. And so what we want to be able to do is create a much stronger data set, because what we really want to get to is the impact. I think once we can start talking about the impact on health outcomes, the impact on economic outcomes of what these specific preemption laws are doing, that's going to be kind of a really useful tool for our second goal, which is making change, right? And putting tools in the hands of our members to be able to go to their state legislatures and kind of demand that these preemptions get reversed and that the power return to cities. It's been fairly rare that preemptions have been reversed. One area where there has been a lot of success is around tobacco control, which was really one of the first areas that we saw kind of a big trend of state preemption around local tobacco control. A lot of those did get reversed. We haven't seen it for a lot of the other policy areas. There was, I think, the first minimum wage preemption repeal happened earlier this legislative session. But we're really hopeful that if armed with that kind of research and the data on the impacts, that our members will be more successful at finding that space there where they can convince their state to just give them the power back, just give us the power back and let us implement these solutions. So with that, I will hand it off and looking forward to the conversation. Thanks.
Well, I want to thank our presenters, because we have actually a good half hour for discussion, and the way we plan to use these panels today is to first give the panel a chance to respond to each other, or any thoughts that left out after they sat down and wish they'd said, or to ask questions of each other. And then after one round of that, we will go to the whole community here. As the moderator, I get to start with my thought and question, and since it was something that Shelley said that really, I think, crystallized a really important point about what we're trying to do with this model of legal mapping in particular, but I think the broader place of legal epidemiology. She talked about, the ranking and spanking model of, say, a TIPA report on obesity, and this lurking sense that maybe there was something not quite happening there that should be happening. And I think what I heard, and when I thought about that in relation to city health, is that it's often really powerful, of course, in advocacy and work to define a problem. I mean, some of the greatest works of social change have been problem works. I was just thinking about like Matthew Desmond's Evicted as a recent example. Like, it just makes you face that problem. But, you also need to have solution work. And I think that's what I think everybody at this panel was kind of talking about that. Jim was talking about, toolkits, and about giving cities their power back, and thinking about how you increase capacity at the local level. And the great thing about city health is that it tells, you can go to city health as a legislator or as an advocate, and you can look at Philadelphia. You can say, well, I'd like Philadelphia to do better. How can it do better? Well, it has to get from silver to gold on paid sick leave. Well, how can they get from silver to gold to unpaid sick leave? Well, they have to increase, you can go to the website, it'll tell you, they have to increase coverage to all companies, not just those, I think it's 10 employers and above, and they have to allow accrual of at least 48 hours of sick leave instead of the 40 that they allow now. That's it. It's exactly what you have to do to make a change. So it's about pointing to the solution. And that's where the granularity comes in, because you can't fix things kind of generally and changing the law. You got which law has to change where. So I think that's something I really pulled out of this that I think is worth thinking about. But I also was wondering, in very practical terms, when we think of cities, the other idea that comes to mind that didn't come up so much, so I wanted to actually particularly ask you guys from NLC and from NACCHO, what about chill? Because the thing that we often hear about is that cities are afraid to be innovators. Yeah, New York can do it, Philly can do it, they can afford lawyers, but if you're Syracuse, you can't afford to defend, a lawsuit against the restaurant association or somebody else. So I'd be interested in your comments on that.
Sure. That's fine. I'm happy. So, no, it's a great question, and it's one that comes up a lot around preemption. I mean, Shelley pointed this out, that there's some fear in the advocacy community around being that first mover who might incur your state's wrath, or, as you point out, incur the wrath potentially of an interest group or something like that. So. I think two things. So one, I think we do have a lot of first mover cities who are less constrained by that. I think what the structure of things like city health do is kind of give those what we would call kind of fast followers the ability to quickly replicate. And it's that replication system that you hear about this all the time, right? That there's this whole network of cities who are innovating together and learning from each other. But a lot of times that can be kind of ambiguous, what that looks like. And I think having a kind of rigorous structure is really important for giving them the confidence to kind of follow in the footsteps of those first movers, especially when, New York has a pretty big city attorney's office and smaller cities might have a part-time city attorney. And so making their job easier, I think, is really important.
Chip?
Yeah, so I really appreciate the question because it's something that's come up a lot in our work recently. And we currently have a project where we're assisting smaller communities in understanding kind of the process in which they could go about adopting different policies that are out there that might improve their community's health. And so one of the questions that does come up is chill and this concerns of litigation coming in the future and they don't want to deal with that issue. They don't have the capacity to deal with that issue. And the way that we've gone about dealing with that in the past is just encouraging the use of partnerships and creating kind of those partnerships, not only with other agencies, other governmental entities, not only with the legislators or the executive branch, but also looking at community-based partners and creating kind of that momentum together. And so I mentioned in one of my slides there is just kind of building up that ability to move forward with political will. And so what we try to encourage with our planning for partnerships activity, as well as with many of our trainings, is create kind of that partnership early on in the process, and then you'll be on the same page once the policy is put on the books. So there shouldn't be any surprises for folks who are those community members, who are those champions for different populations within the community. There shouldn't be any surprises for legislators who might not agree with kind of the policy and the idea, but if they're involved in a process, then they have a chance to understand what the policy actually is, and then have some input towards perhaps how that might be adjusted in order to be more palatable for them. So that kind of partnerships perspective is kind of what we've been using as a tool at NACHO.
Scott, can I add a quick anecdote that I should have added? I won't name the state, but we were in a conversation with a couple cities around preemption, and heard the story that is concerning, but I think points a way forward, which is the largest city in the state had passed a policy. I believe it was around minimum wage. It was on the books for 2 to 3 years, and then a significantly smaller, fiscally strapped city said, "Hey, that looks like a good idea." And really, basically, what was happening was the NRA, the other NRA, the National Restaurant Association, had just been waiting for the venue that they wanted to fight the fight in. And so immediately, once that smaller city passed their ordinance, the lawsuits got filed, and they took the fight to the state. But what they had kind of been prepared here, and I think this is important for at least cities within the same state, is if you're going to get hit with a preemption, especially, that's going to hit every city. So they had kind of a prepared legal sharing agreement, kind of informally going into it. They knew that if the city was going to get hit, that the entire state would be affected. So I think really understanding that there are tactics there are tactics out there that you have to keep an eye out for and be prepared for.
Shelley, would you like to have any thoughts or questions you'd like to jump in with?
Dangerous to give you the mic. No, I'm going to leap off of the preemption. Fear is paralyzing, but leadership, and particularly at the city level, is a difference maker. And I'm going to go back to the San Antonio example, even though we're seeing this play out in a number of places. Alex had noted, there was a concern by many cities and many advocacy groups that if San Antonio passed its Tobacco 21, that would be the great chill effect in Texas, and it would stop. And what happened with very smart collaboration is not only did San Antonio pass its Tobacco 21 because it did the legwork, but it also made sure to reach out to state legislators to understand and be part of the process. And that rather than preemption happening at the state level, San Antonio not only was the first in Texas, but it worked smartly to prevent and actually get passed at the state level Tobacco 21. So it positioned it to be a catalyst rather than a victim of the state efforts. And it's an important one that I think we have to take a look at more, where it's not just cities against states, but in particular, back to this data, when you have places that the population is at greatest risk or is suffering some of the biggest health consequences, where there are proven practical policy solutions that will help that community, then it's in the state and the city's best interest to put those policies in place. And it's that type of collaboration that change can't happen.
Geoff, do you have any thoughts or questions for the other members of the panel?
Yeah, so something that has come up. So when I was looking into my fellow panelists in preparation for this conversation, and I think it's connected to this conversation as well, is just thinking through, and I think this is something that a lot of the audience members are interested in, just communication and messaging to different folks, different entities, those potential partners. Just want to hear thoughts from my fellow panelists. Just how do you go about kind of identifying messages that will resonate with partners or with entities who might at first seem like they might be opposition to what you want to implement, but if you have the right communication, the right messaging, end up being an advocate with you. So I want to hear other folks' thoughts on kind of what you've been able to do within your organizations, within your work in that area.
It's a critical issue to pay attention to, because if we're just out here, I think public health always has the challenge of not sounding like the nannies, and out there saying we know best on what you should have or what policies. And just in terms of making sure that as we put a menu out of policy solutions for the city leaders, we did a lot of message testing. We did public opinion research at a few different levels. And one was a series of individual interviews. We hired an independent firm that brought in Republican and Democratic pollsters that conducted interviews with mayors, council members, city managers to understand the policies that we were looking at and considering. What were the issues and concerns? What were the language? And then to be prepared. But we did and that there was some possible things to often it was on equality. We had to find the data and framing that would translate our policies into why they were fixes for the issues that were front and center for them, that these were not just boutique nice issues, but in fact were core to the health and economic vitality of a city.
Alex?
Sure. So I'll just add a few things. So one messaging lesson I think we learned pretty quickly was to never use the word preemption, which is tough when you're talking about preemption. People's eyes just glaze over, and half of even our membership aren't quite sure what it is. So kind of in addition to what Shelley said, I think we've really kind of been working on articulating what I call kind of like an affirmative vision for local democracy and for kind of local governance, and it's kind of around that innovation and autonomy kind of idea, and so we're one of the efforts that we're kind of evolved out of this work is rethinking and rearticulating a statement of home rule principles for cities. That goes beyond, I think the last time they were rewritten was 60 years ago, and it was by the predecessor to NLC. And so we really think that our members need that kind of positive message to take out to their constituents and to their legislatures. Otherwise, it just becomes this kind of back and forth. It becomes that kind of conflict that it doesn't need to be, as Shelley said.
In the field of law enforcement and public health, what's kind of ironic is that law enforcement leaders are actually leading the charge in many ways in cities to change how they do business. So they're not dragging their feet right now. It's become such a system overload problem that police chiefs are actually using new language and reframing issues to their own people and saying we can't arrest our way out of this. And at the same time, what's been going on is there's been increasing attention to officer wellness. Officer suicide rates are remarkably high. Officer burnout is high, officer trauma is very high, and that's all happening in this space at the moment now, that for our own health and wellness, we need to find a different way of dealing with these issues. And if we're not well, we are not going to treat people on the streets in any type of way that's procedurally just. So there's a lot of different connected pieces here. Sadly, it took a crisis like the opioid crisis and the gun violence crisis has been going on for a while, but to really almost launch this paradigm shift in the framing language of police leaders.
I wanted to pick up on a couple of themes of that last set of questions. One thing I want to put in a plug, we have another de Beaumont Foundation sort of supported project has been to, it's called Crafting Richer Messages for Public Health. And on the de Beaumont website, there's a few links and so on about that, which is just talking about sort of framing. But, the problem with framing is you're always in the perpetual present. What's on people's minds now? What is the playing field they're on now? And, for a lot of what we're doing with structural change in public health and deep social change, you have to be thinking on 10 and 20-year timeframes. The fight you want to have is what framing will make sense to people 20 years from now, and you want it to be a framing that will support your issues. So, for example, one of the things that I would love to see in city health one of these days is a sin tax. Get an alcohol excise tax increase onto the list, because we've got to be changing the dialogue about revenue and taxes, because there is no successful collective work without the money that pays for the staff who inspects houses and the staff that inspect restaurants and for the parks and infrastructure and so on. So, there's that sort of deeper thing. And that's where I think, when something, a strategy like, well, let's reframe how we think of cities and start to spend a lot of time getting people to be conscious and aware and thinking about cities as a positive force, maybe that they don't think now. In a way, I think legal epi functions in that same way. One of the things that we would like to have is coherent legal strategies supported by interventions like city health across all these cities and towns. And that means we have to have people who have the capacity and capability and understanding to take those tools and use them. And one of the things that's, I think, been true about public health law as a part of public health is that there's a kind of translation function that you have to go through when you go from one town to another, because we haven't had kind of a common language that's sufficient to bring together and coordinate the activity of lawyers and non-lawyers in the world of public health, so that they can effectively work together, not just within institutions, but across institutions and across cities and across organizations. When we think of strategies for change, giving people new tools, but also giving them a common language is a big part of what we're doing over the long term. But I'm going to stop now and think, Alex, is it your turn to pose a question? Shelley has done so, and then.
Oh, sure. I'll pose, kind of a related question, and your presentation made me think about it. But I think also probably relevant for the health officers as well is like, one of the things we see in cities a lot is this kind of silos, and those silos are normally driven by incentives, right? Of like how these people's jobs are evaluated. And so it strikes me that you were kind of describing almost a shifting incentive structure driven by the officers themselves. So like, could you go a little bit deeper on is that actually changing, or is it just purely because kind of the crisis has gotten so dire that they understand that they need to work differently, or is the way they are evaluated changing?
It's a great question. I mean, the diagnosis of this problem of mass incarceration and the role of police as the gatekeepers and as contributors to mass incarceration is that there are perverse incentives built into the operations of the criminal justice system that exacerbate this problem. So officers aren't rewarded for thinking about health. They're not rewarded for using tools that are alternative tools to law enforcement tools. They're rewarded for generating activity. That's the language. They're rewarded for arrests. They're rewarded for citations. It's well accepted now that we have these perverse incentives in place. So police agencies are beginning to restructure their you use law enforcement with prudence, when you do not use force when unnecessary. And so we are seeing traditional paradigms that, such as CompStat, where, which is a computerized statistics program where they look at, how many arrests are we making in hot spots. And so that's now being sort of looked at in a more holistic way to say, what are the variety of outcomes that we can measure officers' work against, to see holistically if they are not only improving public safety, but helping people address their unmet needs. So it's the needle's beginning to move, but it's a huge problem, a huge problem.
And with that great answer, do you have another comment or question you'd like to pose?
Well, I guess I have a question for the other panelists around how to support this type of legal mapping that Shelley was talking about. What, for me, an area that hasn't been explored yet is what laws and policies need to be in place in cities, what changes need to be made to support work that allows police to, work with health in mind. Are there changes to criminal laws? Are there changes to drug laws? Are there changes to the way in which mental health laws operate, in involuntary psychiatric hospitalization, for example? So the legal structure underpinning police work, is there a research agenda there to understand what do we need to do foundationally at the legal level to better harmonize law enforcement and public health? And I know that that's a topic in a later session today, but I thought I'd throw that out there, how to tie into the type of work Shelley is doing.
I mean, I think that's a bingo question. It's actually for the whole group. We've put together an extraordinary database. I keep saying it's powered by Legal Sciences and Lizzie Platt. I can't thank them enough for the analysis and work that's taken place. But I also, we have a treasure trove of data on extensive analysis on these 40 cities that could start being used more. It's like what NLC has been doing with us and taking this data and combining it with some health outcomes. There is so much more that could be done. And I would love to, both ideas on how we can make that more on the radar screen for people to incentivize the research. cityhealth.org. Go in there. It's wild, it's public, and there's all kinds of possibilities of what can be done. But back also to your question in terms of this intersection on public safety and what cities can do in the data sets, we actually were supposed to have 10 policies. We have 9. The 10th was supposed to be around mental health and substance abuse and/or. Step 1 in our work is to have upstream policy solutions that there's an evidence base, they'll make a difference. And from that pool of policies, we then go through what's city jurisdiction and what's pragmatic. We didn't have a pool. We didn't have an upstream prevention-based policy out there for us to put in. The closest we got was in the public safety, was on alcohol outlet density. I would love to have the 2 clear data policy points that is out there is both an alcohol tax that has a very good evidence base on driving down violent crime rates, extraordinary correlations. Same with alcohol outlet density. Taxing was predominantly outside the jurisdiction of most cities, so we popped it out. Alcohol outlet density, if you take a look at the data there, from a public safety standpoint, this is a no-brainer. You talk about regulating safe sales of alcohol, it's a whole different can of worms from a policy standpoint. You want to talk about an opposition, and there's no advocacy group. But there's also no research really being done on connecting these dots. And this is where in public health, we actually have very few organizations that are engaging on this kind of level of intersection on policy and outcome. It is a new shift. I love your framing that you did, Scott, of that you said I did, but I'm going to say that you helped helped translate it. We're really good at problem identification. That's our bread and butter. And we've been looking at more and more on the policy solutions. The data is showing that if you want to improve an equitable way health outcomes, policies are the solutions. That's much of what germinated City Health. But it's a thin data set. It's a dim limited research body, and we need help in this area. And I would love to hear the ideas and thoughts and collaborations and the possibilities in this audience, on the webinar. I really would invite, we are open just the way we're working with NLC, we're doing work with NACCHO. Obviously, we've been, our bedrock is the work that's taken place here, very open to further ideas and how to make sure this data makes a difference and that we're identifying and driving the right policy solutions.
Well, so on that note, let's put it out to you all. We have at least one request from the panel for ideas for using and expanding City Health. So think about that if you have some thoughts, and otherwise I already see a hand. Nick?
Thank you, great panel, really enjoyed it. So Shelley, I think your examples of local metrics are pretty much unassailable. Wouldn't it be great if we all had them? And the appeal of think locally, act locally, democratic appeal is pretty obvious. But what happens when you flip it on its head and you have a state policy that perhaps has a stronger public health focus than municipalities? And clearly we're seeing that in the syringe service space. In my own state of Indiana, where we have 92 counties, for a relatively small state, we have tremendous local opposition to syringe services, and our state statute permits them to block. We're seeing a similar kind of problem in West Virginia at the moment with UHIV outbreak, which I think at least you can in part blame on local animosity to such services. So I wonder how you balance those two types of problems.
I'm going to jump first, but we'll tag team here. Excellent point. And I'm not sure how other panelists would respond, but my absolute priority is for a national policy first and foremost. And assuming it's the strongest that you can get. State is secondary and cities last. Now they may be the incubator and making it happen, or in the absence of national and state leadership, which is, I would make an argument, what we're experiencing right now. Cities are the place of action. So it's better that Tobacco 21 not pass at Texas or San Antonio, but that there really is, and there is discussion now of a Tobacco 21 law of the land. And with the presumption that it could be a really good one. I think this is, to your point of, can it be better or best practices? Then that's ideal because the entire country is covered.
Yes, I mean, that's a fantastic question and something that we are working on every day with our HIV team, especially in West Virginia, on kind of the issues that they're facing out there. Really our primary kind of technique to kind of work on issues similar to that is trying to convene and create a forum for folks to share kind of different ways in which the existing policies that are benefiting public health could benefit their jurisdictions as well. So just trying to provide that kind of space in order to share these ideas and perhaps change minds and change ideas as to kind of the benefits of some of these programs rather than looking at them as a detriment only. And so that's why I mentioned in one of my last slides is having that kind of national space to convene folks to have this conversation, kind of having those group sharing opportunities, providing different ways to allow folks to kind of collaborate and think about these topics. And then providing them with the tools and resources to discuss these topics with their community members and with those other folks in their communities who might be against some of these ideas. I mean, most of the time, this is not coming from my members, not coming from our local health departments. It's coming from folks who are working on, who want to represent their community's ideas and their community's thoughts. So it's just a matter of kind of providing that information to them in order to understand or hopefully make a decision that allows them to see that some of these things that they might see as a detriment is actually more of a positive.
Yeah, I'll just quickly respond. So obviously at the National League of Cities, we kind of have the luxury of not being ambivalent around local power. But that said, I think we're very cognizant about the benefits of, as I said, preemption can be good and bad. And I think our main push here is to kind of raise the threshold from where it currently sits in a lot of states to a higher level of justification for that trade-off, which is a real trade-off between implementing a statewide policy. When implementing a statewide policy requires restricting kind of local input or local action, but we're very open about the fact that there are some clear problems that require that. Right, there are moral hazard problems. There are kind of what you're describing is if people use the phrase lose locally undesirable land uses. There are places where, and in housing, we just did a big housing task force at NLC, and we're pretty open about acknowledging the kind of pernicious role that some local policy plays there when you have regional housing markets. So, all I would say is that the kind of burden of proof that we look for from the state legislature, from the federal government, should just be a little bit higher than it currently set.
That's a nice way to put it. Yes.
Yes. Some ramifications about public health. I went to public high school in Cincinnati. Went back and I found out there was no school nurse anymore. Also, there was no cafeteria anymore. When I was there, and the school had 3,500 kids in it when I went there, there was a school nurse and there was a cafeteria. I don't think it's just apocryphal. I think that there's a systemic problem in that health personnel have been eliminated at a lot of public schools. There's no longer school nurses. Cafeterias have been closed, and there's like McDonald's gets contracts to bring unhealthy food to kids. So there's a problem with healthcare in the schools. Also, I worked as a volunteer in the 70s with Attica Brothers Legal Defense. There was a rebellion in Attica prison, 44 people were killed. One of the main demands of the prisoners was better health care. I think prison physicians. I think the situation is far worse now than it was in 1973 or so when Attica took place. So what about healthcare professionals being placed in the schools where there's 40 million people or so, and in the prisons where there's 2.5 to 3 million people, disproportionately minorities? And what about the whole issue of racism in the delivery of public health care? There's only 2% of the attorneys in Philadelphia are Black, according to what I see in the Legal Intelligencer every year. One extra person gets hired, and they say there's been improvement. What about the concretely putting more healthcare personnel in the schools and the prisons? What's being done about that?
I bet you we kind of say amen on that one. But I do want to, I really appreciate your bringing up the sort of social reality of who we are and what we think, and who we think is important, who we think is not important, because I tend to, with public health people, we get very kind of positive, and we're going to just say, let's do this and let's do this, and here's a solution. But there are no solutions that aren't really embracing and thinking about and being based on a recognition of who gets health and who doesn't, who has resources and who doesn't. And also just the problem of going back to what happens when you starve institutions, and how are they supposed to provide what we used to think of as basic services when they don't have the budget. And I would just call upon this to be kind of a theme for the day. I want to try and actually we've hit 10:15. One more question.
concerning the presentation on the police, what is the attitude of the high-level police administration toward your monitoring of police arrest activity? And what techniques are you suggesting that should be used to get them to see the validity of your position?
Okay. The police are required to produce public data on their arrests and now how many jurisdictions can stop and frisk activities. So there's a great deal of transparency there, and their argument we need others. Right. So in what's contributing to their own wellness problems, we have no other option, no resources. Back to other institutions. We don't have social infrastructure that we to support us in doing things differently. And so they recognize that law enforcement has many negative implications, but when an officer is standing there and they have very limited options to resolve an encounter, sometimes they will arrest somebody, what's called mercy booking, simply to get somebody help through the jails and prison system. So, ironically, to your point about prisons, they have become de facto health institutions. And very expensive ones. Well, there's a lot of money being spent on.
They may not be good health institutions.
I'm not saying they're good health institutions.
I agree with you.
Right.
Yeah, and I think we're making slightly different points. I agree with you that there's. Well, okay. Anyway. We'll talk at the break, but the point is that if the community supports police in doing something differently and building up those social institutions, that's what's going to allow them to do it. So what they're doing now is forging relationships with behavioral health services to say, at least give us a tool, give us a clinician to come out with us and co-respond during certain situations. Train us in crisis intervention, help us at least do what we can with the resources that we have available to us. But it really gets down to these fundamental absence of health and social institutions that can support work and furtherance of public health. So what that means is we shouldn't be demonizing the police. That's not a constructive response. We have to look at the city level, at the policies, the laws, the institutions that would allow us to align safety and public health. So there's a much bigger, more complex dynamic there.
Well, so big and complex, that's kind of the theme. We will continue these conversations throughout the day, and then we have at the end of the day a chance to just dump all this that hasn't yet been said and needs to be said out on the table. So save any thoughts that if you didn't get a chance to come in. I would like to leave you with one idea from this session. Imagine that law is a medicine. And that and you don't have to imagine, we in fact are treating entire populations with laws. We hope that they're going to have an effect. With medicines, we generally try and test them before we try them. And anyway, we try to have an idea of what the right dose is, and we try to make sure that they actually do what they're supposed to do. We largely don't do that with law. And then, when we have medicines for better or for worse, we market them everywhere so that all the patients who possibly need them, and unfortunately sometimes patients who don't need them, get those drugs. Well, that's sort of what we're talking about here in legal epi, that we would like to know as quickly as possible whether these laws or legal interventions or police activities are actually doing something good. And if they're not doing something good, we want to pull them off the market as quickly as possible. And if they are doing something good, we want to be systematic and strategic as Merck, in getting those laws to everybody who needs them as quickly as possible, which, I think is what the work that you're all doing, and I thank you for it. And now I invite everybody to have some coffee and mingle, and we will start up at about 25 minutes with our next session.
scared you had a story from we met like 12 years ago.